And I'm going to introduce our last speaker of the day, last but not least, Robin Green, who's a senior scientist at the Toronto Rehab Institute, University Health Network, and part of our concussion center, talking about neuropsychiatric and cognitive treatment targets in retired CFL players.
Thank you, Carmela. So I'm going to give you a brief overview of some of the clinical work that we're doing at the Canadian Concussion Centre. So, oops. Okay. In the first part of the talk, I'm going to give you a recap of some previously presented findings on the characterization of cognitive and neuropsychiatric function in retired CFL players who have a history of multiple concussions. And we've been working with the CFL players for a number of years now in an effort to try to understand this group, to clinically characterize them. And in the second part of the talk, I'm going to talk about some of the recent findings that we haven't presented before on understanding the mechanisms of dysfunction in order to help to reveal treatment targets. And then in the third part of the talk, I'll speak about our preliminary treatment research. So, for this first goal of characterizing the retired players, why are we interested in doing this? Well, first of all, this population serves as a model for understanding the chronic effects of multiple concussions and subconcussions. They're also a large and important population in and of themselves, and we're interested in providing clinical care for the retired professional athletes and also amateur athletes in contact sports who have similar concussion histories. We're also trying to gain this better understanding of this population to be able to advise new up-and-coming athletes on long-term risks. So, the population that we're working with, it seems, as compared to the previous presentation by Anne, it feels like a case series now with a sample size of 50. Because the numbers in her studies were so large. But anyway, we've studied 50 players and 30 closely matched controls. And as you can see, they're matched on age. There's no significant difference there. Years of education, estimated premorbid IQ. And the controls have no history of concussion, and they have no history of participation in contact sports. So we also studied a subgroup of the football players, and I'll explain why in a moment. We divided the football players after the precedent of Goosewitz et al. Into a low concussion exposure and a high concussion exposure group. We opted for this more coarse dichotomization of the group because we know that there's only a moderate reliability of providing concussion history by this population. It was shown by Curran, and it's hard to the definition of concussion that football players use is not the same as the rest of us. They tend to use a much higher threshold for something that constitutes a concussion. For example, for many of the players that we've talked to, what counts as a concussion is an event whereby they have to watch the video of the game that they were in the next day or the next week because they have absolutely no recollection of it. So as you can see, the subgroups fortuitously are well matched to one another, the low concussion and high concussion exposure group, and they're well matched to the controls. They're well matched for age, for years of education, and for estimated premorbid IQ as well, and years played in the CFL. And I don't think that I flagged before that in terms of self-reported concussions, so we did a median split, and we broke the groups up into those with 3 or fewer concussions and those with 4 or more. And as you can see, we get these 2 groups, one with just under 2 concussions on average and the other with 6.5 concussions on average. In terms of the outcomes we use, so to look at neuropsychiatric outcomes, we use the personality assessment inventory, and we looked at their group scores on the scales below, and we also looked at the number of individuals who met clinical threshold on the PAI. And we focused in particular, I'm flagging that I'm going to be talking in particular about the scores on the depression, mania, and aggression scales. We also carried out so as I say, this is a self-report measure. We also carried out a very widely used diagnostic interview that's based on the clinical criteria of the DSM-4. And here we were wanting to just look at the frequency counts, the number of people who had diagnoses on this clinical interview, in addition to our group data. And the cognitive outcomes we looked at, so we did a very comprehensive neuropsychological assessment battery, and our particular interest was the addition of a cognitive executive control measure. And this is, by cognitive control or executive control, I'm talking about control over one's own cognitive functioning. So this is measured by inhibitory control, or you can think of this as inhibitory control, control of our impulses, also our consistency of responding. And we're interested in this because it hasn't been looked at in retired CFL players, but there are indications that it might be compromised based on studies of related populations like amateur athletes with histories of concussion. Cognitively, so I mentioned that we did undertook a comprehensive battery, and then the measure that we used for measuring executive control, though, was the sustained attention to response test, and this is a go, no-go reaction time measure. It measures both sustained attention and also inhibitory control. And our outcome measures were errors of commission and also intra-individual variability. So how consistently an individual is responding to trials within the task. So for example, on a reaction time task, are they on one trial responding very quickly and then on the next trial responding slowly? So just to recap findings that we've presented before at the conference, the full group of retired CFL players scored significantly higher on mania and aggression scale scores. And they also showed higher incidences, individual incidences on past manic and hypomanic episodes on the mini, and more clinical diagnoses on the PAI. I'll come back to that in a second. And they scored significantly worse on the measure of cognitive control. And these were the only measures that discriminated the retired CFL players from the controls, despite their complaints of pretty significant changes in their functioning. And I'm going to come back at the end to some of the challenges, briefly, some of the challenges of picking up the deficits in this group. But there's a paper coming out, it's in press by Levine and colleagues, where they were looking at hockey players, and in that study they didn't find any cognitive differences between the groups. It's really difficult to pick up the findings, so it seems important to us that we were finding this effect in the executive control, which hadn't been looked at before. Now, are these findings secondary to concussions, or might they be pre-injury characteristics? The football players are a unique cohort. To play elite football, certainly you need personality characteristics that are related to some of the elevations that one sees on the clinical scales like mania and aggression. So of course you need to be aggressive. The players have robust egos. And so is this pre-morbid or is this acquired? So that was why, one of the reasons that we broke the group up into the high concussion exposure and the lower concussion exposure. And what we saw was a really notable separation between the groups as a function of concussion exposure. So we saw significantly higher mania and aggression again on the group data, and also depression came out once we split the groups up in this way. In terms of the clinical diagnoses on the mini, so what I want to flag is that in terms of the group scores on the PAI for the mania, aggression, and depression, these are not, the group means are not into the clinical range. But it's important to note that when we look at the clinical diagnoses, the individual diagnoses, we have a much higher rate of clinical diagnoses in the high concussion as compared to the low concussion group. So on depression, 18% versus none, and on the history of manic and hypomanic episodes, 39% versus 5%. And we also, in the higher concussion exposure group, saw significantly reduced executive control. So, building on these initial findings, and in an effort to reveal treatment targets, we asked the question whether cognitive dyscontrol might mediate the relationship between concussion exposure and the neuropsychiatric deficits. Reduced cognitive control has been associated with mania, aggression, and depression. So think of in mania, increased impulsivity, and in depression, think about rumination, for example. Those are examples of reduced cognitive control. So we asked the question whether reduced executive control contributes to the neuropsychiatric dysfunction in those players with elevated concussion exposure. So does high concussion exposure result in reduced cognitive control? And does reduced cognitive control in turn contribute to the elevated neuropsychiatric dysfunction? And if yes, if the answer is yes, then that offers us a treatment target. It means that we can go after executive dyscontrol to try to influence the neuropsychiatric symptoms. Okay, and so we ran mediation analyses, and in a nutshell, we found that executive control partially mediated the relationship of concussion exposure with depression, and fully mediated the relationship between concussion exposure and mania, and concussion exposure and aggression. So we found, in summary so far, high concussion exposure is associated with elevated neuropsychiatric symptoms. There are group differences on mania, aggression, and depression scales, and a higher frequency of clinical diagnoses on both the MINI and on the PAI. And we also see reduced cognitive control. And reduced cognitive control, as I just described, appears to mediate the relationship between concussion exposure and neuropsychiatric symptoms. And one of the interpretations for us, I was asking the question about acquired versus pre-morbid and the uniqueness of this cohort. And one interpretation is that this reduced ability for cognitive control might be exacerbating pre-morbid characteristics and bringing these characteristics into the clinically significant realm. Okay, so in terms of treatment implications, we need to target symptoms of mania, aggression, and depression, and we can try to target executive functioning as because of the elevations in and of itself, but also we can try to target executive dyscontrol or cognitive dyscontrol in an effort to reduce the neuropsychiatric symptoms. So this characterization research so far is offering us some directions for our treatment research. And I will now just overview this treatment research in progress. So our research has been to assess the feasibility and preliminary efficacy of a combination therapy intervention for cognitive functioning and for mood. And our goal was to deliver this intervention both face-to-face but also remotely. We've been delivering it over the internet as well because the players that we're working with come from all over Canada. And very quickly, this is what the protocol looks like. So we give 9 weeks of goal management training, and this is important for goal management training helps people to stay on task, to formulate goals and to execute goals. And we also give 11 weeks of cognitive behavior therapy, a form of talk therapy that has excellent efficacy in the literature, and which our group has demonstrated that we can effectively deliver online in previous research. We also do mindfulness, meditation, and environmental enrichment intervention. I'm not going to talk about those findings. So far, as I say, we're really still in the early stages. We've recruited 14 patients, 11 completed the full protocol, 3 were lost to attrition, and that was related to scheduling issues and cognitive difficulties. So one of the individuals was too cognitively compromised to keep up, but not because encouragingly, they weren't dropping out because they didn't want to participate, they didn't like the intervention. In terms of acceptability, very good feedback. I'll let you have a look at some of the comments. In particular, it's considered relevant, and people would actually were saying that they would integrate the strategies that they learned into their everyday lives. I forgot to mention that the interventions are group-based. And in terms of the preliminary data on efficacy, all the data are behaving as they should. So in terms of emotional functioning, their stress, depression, their stress and anxiety levels are dropping. Their depression scores actually were not too bad, actually, pre-treatment. So we don't see any drop there. In terms of executive functioning, also behaving as they should on a measure of goal management training. And this is a measure that looks at the measures by the individual themselves as well as by family members. And these are questions like, I went into the room and I forgot what I was going to do. Also, another index of executive functioning showing improvements pre-post. Okay, so in terms of the next steps for us, we want to test the hypothesis that improving cognitive control will improve neuropsychiatric function, and we're just starting to think about the RCT to do that. We haven't embarked on that study yet. And just in conclusion, to summarize core impairments that we found in our study, cognitive finding, the only cognitive finding, again, we found was executive discontrol. In terms of neuropsychiatric functioning, we saw, and I should mention that all of these withstood control for multiple comparisons. Mania symptoms, depression, and aggression. The findings can't be attributable to premorbid traits, but they might be an exacerbation of premorbid traits. We found that executive control appears to mediate the relationship between concussion exposure and the psychiatric manifestations. We found that retired CFL players are receptive to and they comply with the talk therapy. What I didn't mention, and with regard to the other intervention that they had to do on their own, that was the environmental enrichment one, they were not so compliant. So they weren't as big on doing their homework, but they turned up to all of the therapy sessions, and they were very engaged at the therapy sessions, and they, in our preliminary efficacy data, benefited from that. The therapy can be delivered both remotely and face-to-face. And as I mentioned, next steps test that hypothesis that treating cognitive control will ameliorate or prevent neuropsychiatric symptoms. And here's our lab. Thank you very much.
Has any? Want to come up to a microphone?
It's just a quick question. What methodology did you use to do it remotely?
What methodology? We used, do you mean what technology we were using? We used a bridge to OTN, and we used group, video.
Could you just review, please, your operational definition of executive control? It sounded like it was measures from the SART.
That's right.
And which of the measures from the SART?
Areas of co-mission and intra-individual variability. And so
Variability of reaction time?
that's right. So
And errors of
co-mission.
So impulsive and drifting attention.
You can call it drifting attention, sure, or reliability of responding. And intra-individually, in the interest of time, I didn't discuss those outcomes very in any detail. Intra-individual variability is simply calculated by taking the standard deviation of the reaction time and dividing that by the reaction time itself. And that gives you an index of, as I say, how consistently people are responding.
In your pre-control population, you looked at people that didn't play any contact sports. Would you consider looking at athletes that don't have a history of concussion but do play contact sports as they might have different psychiatric conditions?
Right. So I said I would come back to the measurement issue that you're speaking to. That was the original design of our study was actually to include kickers. So we wanted people who were who as closely resembled the players with a history of concussion as possible, but who wouldn't have this history of concussion. And unfortunately, that turned out to be untenable because the kickers actually in Canada play in all positions before, and so they had comparable exposures, concussion rates, subconcussive rates. And so it is a problem, and we're aware that the football players are different. They're kind of superhuman in certain ways. Just abandon the notion of dumb jocks when you think of elite professional football players. In order to play at that level, you have to first of all learn this playbook, and it's a particularly challenging kind of visuospatial information that you need to learn. You need a particular kind of allocentric spatial navigation learning to do that, which itself is known to confer benefits to the hippocampi. So basically you're starting off with memory capacities that much of the rest of the population doesn't have. And also, as I mentioned, in terms of personality characteristics, these are different individuals too, particularly in the realm of aggression. So this is an issue, and we're trying to come up with creative ways to try to have the appropriate control group. We've been thinking about trying to develop normative data for this population, and we're trying to think how we can find individuals with a similar history, but who have a similar sporting history, but without the history of concussions. Right, we've thought about that, and then the question is, is there the same need for very, very rapid speed of processing, the memory that I mentioned, the multitasking capacities that are necessary to play elite football? So for example, one thinks of swimmers, but swimming does not necessitate the same kind of cognitive demands that professional football does. Okay. So before we hand the mic over to Charles.
No, we just wanted to, first of all, thank you all for coming and for staying till the very end. And I'm not sure, maybe some people already alluded to this, but Dr. Charles Tatter, who was already an officer, had the Order of Canada at the member level, was upgraded to an officer, and we wanted to congratulate him.
Yeah. So thanks for your service to Canada, Charles.
Well, in turn, I would like to thank our keynote speaker. Thank you, Grant, for coming. I know you have to be off. Safe travels home. We appreciate it greatly. Thank you to Julian, who had to leave earlier. Safe trip. Thank you to Ken Dryden for his illuminating talk. Thank you to Robin and Carmela for being chairs of the sessions. We worked very hard on the program, and you made some great decisions. The people who actually did the work for this meeting, Mojgan, thank you for your input. Christian, I'm not sure if you can hear me in the booth. Kim Hussey and Jill Fredericks were the people who look after this facility, and we're grateful to you for all the work that you put into it. Everyone who spoke added to knowledge translation. Thank you, speakers and poster presenters. You all contributed greatly to making this a great learning experience. And we certainly hope that you'll be back next year. So thanks again. Bye-bye.